Hello and welcome. I want to say welcome to those of us who have joined us on the East Coast and good morning to those of us who have joined us in the Western time zones. We wanted to welcome you today to our trauma-informed care across the Intercepts virtual learning community. Today is session 1 and we will be focusing on Intercepts 0 and 1, which is community services and law enforcement. Today, we're going to start with some introductions and just to go over some virtual learning community goals for our time together. And I wanted to start with introducing today's facilitators, and we're going to each take our own introduction. So I will kick it over to Dr. Callahan to start us off.
Thank you, Ethan. Welcome everybody to the virtual learning community on trauma across the SIM. My name is Lisa Callahan. And looking over all the grantees, I'm familiar with some of you and have actually, I think, provided some trauma training in your communities. I work at Policy Research Associates, which is the home of the Gain Center. Many of you have probably heard of the Gain Center. And we provide technical assistance to communities and others around the issues of criminal justice and mental health. And I'm happy to be working with CSG on this learning community.
Thank you. My name is Ethan Kelly. I'm a senior policy analyst in the Behavioral Health Division at CSG Justice Center. Here at the Justice Center, I provide technical assistance to JMHCP grantees. I am also involved in project work here at the Justice Center, which involves the Judges and Psychiatrists Leadership Initiative, providing judicial education around mental health. Previously, I've worked in, I'm from Connecticut, and I've worked in several pretrial mental health programs as a clinical supervisor. And so that's where my experience comes from for this.
Hello everyone, my name is Ashley Carter. I work with Lisa Callahan at Policy Research, and I've been there for about 8 years and worked on a lot of the Gain Center initiatives that she mentioned. And right now I'm focused on the MacArthur Safety and Justice Challenge, which is all around reducing unnecessary incarceration in local jails across the country. Happy to be here.
Hi everyone, welcome. My name is Rachel Lee. I'm a policy analyst at the Justice Center. I provide TA to JMHCP grantees as well as some project work on mental health diversion and substance addiction. And I have a background in social work, so have worked in both inpatient and outpatient clinical settings, as well as with a SAMHSA contract to bring peers into the field in different settings.
Great, and hi everyone, my name is Allison Upton. I'm a project manager in the Behavioral Health Division, also here at the Council of State Governments Justice Center. And let's see, I've been here for about 4 years, and I provide technical assistance directly to Justice and Mental Health Collaboration Program, JMHCP for short, JMHCP grantees, and I also oversee a lot of the administrative and technical assistance for Category 3 grantees within the JMHCP program. Let's see, I also do some project work at and policy work at this intersection of behavioral health and criminal justice systems. And prior to the Justice Center, my training background is as a clinical psychologist, so I've worked in a variety of mental health, sort of more traditional mental health settings, but also in court and jail-based programs where we did certainly, interacted with a lot of people with trauma histories and tried to be as trauma-informed as possible. So, just very excited to be on this in this learning community session today. So if we can just go to the next slide, just want to say thank you to all of the facilitators today for joining us. And, welcome and thank you to all of you, all the teams out there that are joining the session today. We're really excited to work with you together here today. And we're just going to start off this series of learning community sessions by giving you just a brief overview of the agencies involved in the learning community on our end of things. So I'll just start off with the agency where Ethan, Rachel, and I work, which again is the Council of State Governments Justice Center, or CSG Justice Center for short. So you can see our mission statement here listed on the slide. And I'll just point out that we as an agency really pride ourselves on taking an independent, nonpartisan approach. We pride ourselves on our ability to gather people from both sides of the aisle and all areas of the country to foster collaboration and to promote best practices and data-driven solutions. And so I believe many of you, or all of you maybe, should know either Ethan, Rachel, myself, or one of our colleagues here at the Justice Center. You probably should have be working with a technical assistance coach or TA coach. And our agency, the Justice Center, is the agency that provides technical assistance to Justice and Mental Health Collaboration Program grantees. So pretty sure you know one of our colleagues as well. And then if we can just go to the next slide about JMHCP. So I know you are all familiar with the Justice and Mental Health Collaboration Program, JMHCP, because this is your grant award, which we're very happy that you have. And on this slide, you can see sort of the one overarching goal of the JMHCP. And I'm not sure, many of you may know this already, especially if you have had JMHCP grantees previously, but there's actually quite a range of types of project work that is funded through the JMHCP, all the way, really speaking of the Intercepts, which is part of the focus of this learning community, we have really work funded across all of the Intercepts, from the earliest point of Intercepts, sort of pre-arrest law enforcement projects, all the way through pretrial diversion programs, court-based programs, jail, and then reentry programs. So, but despite all these sort of different areas of focus, I think that what you can see on this slide is really sort of the common thread, the essence of what you're trying to, hoping to achieve through all of your grant-related work. And this learning community in particular is one of the innovative strategies that's been developed to help support your work with the participants, and it's actually directly funded through the JMHCP. And if we go to this next slide, you can read the mission statement of the Bureau of Justice Assistance, or BJA. Within BJA, you may know that it's the Office of Justice Programs that directly oversees the JMHCP. So really want to mention them today because we are very grateful. It's through their support that we are able to have these learning community opportunities for grantees. So we're very grateful to them. Okay, with that, I will turn it over to Dr. Lisa Callahan. You started to talk about Policy Research Associates, but just to provide any other brief comments as far as an introduction to your agency. Dr. Callahan?
Thank you, Allison. Yes, just a little bit more about PRA. The work we've been in business since 1987, and the GAIN Center has been funded for about 25 years, funded by SAMHSA, as well as some other technical assistance centers, such as the SMBF and the SOAR. Many of you probably are familiar with the SOAR Center. And we've collaborated on a number of projects over the years with CSG. We also have, as part of PRA, a not-profit partner agent company called PRI, which is where the MacArthur work that Ashley mentioned that she's deeply involved with is housed. And while our work has evolved over the 30 or more years that we've been in business, the focus has always been, the mission has always been to provide services and to improve the lives of people who have disadvantages, whether it's due to behavioral health, economics, or other disadvantages, and to work with communities to improve services to those individuals and to those communities. So we're happy to be here. Trauma has been a part of our wheelhouse now for over 10 years. We have a trauma training and a train the trainer that we have been delivering for about 8 years, and we have delivered it well over 100 times. It's also the home of the sequential intercept model, which is the conceptual framework for this virtual learning community. And Ashley's going to talk more about the SIM when we get to that section of the program today. So thank you.
Thank you, Dr. Callahan. So just to cover what to expect while we're here together. So the goal is to have 3 content and discussion sessions with 1 follow-up session in September. And I will discuss a date later on today to put people on notice about that and see about calendars. Our goal here is to certainly provide an interactive forum between grantees. I think looking at the current climate of our communities, the jurisdictions, I think this is a really, really unique opportunity, particularly for the group that's here today, to really start to have some of these discussions together. Certainly, and as Dr. Callahan was saying, an opportunity to interact with a national expert on these learning communities. Today, Dr. Callahan has Ashley with her. She'll also be bringing in another colleague, so certainly be able to have a few options there. And last, to engage in some brief exercise between sessions. We're not going to overload you with homework. We understand time demands, but I think this is an opportunity to start to become familiar with the terminology you're going to hear today, the concepts, the principles, and to really be able to kind of just put those into some real life scenarios and within your own organizations and programs. So I'd like to turn it over to all of you to start some team introductions. And as you can see here, we're just asking for a few things. A lot of people on the line today. We really want an opportunity to hear from everybody. We are curious and interested. So introducing yourself, whoever the representative of the grant team is. So introducing yourself and your role on the team. Introducing any team members with you today in attendance. And then just to let us know one thing you would like all of us to know about your project and team. And we're going to do this in an alphabetical order. And so I will have our grantees up. And so looking at this chart, we're actually going to be starting with Chatham County today. Battle Creek was unable to make it. So I will turn it over to Chatham County whenever they are ready to begin.
Hi, so everyone can hear me okay?
We can.
I'm Charity Collier, and I'm the project coordinator here at Chatham County's Criminal Justice Advisory Council project. And I am joined with Tara Jennings, and she is the Chatham County Business Strategic Planning Administrator. And a little bit about us, we are, in Southern Georgia, and we are working starting from Intercept 0 all the way through to have develop systems of levels of data-driven to reduce the booking rates of people with mental health and recidivism of people with mental health in the detention center and across the sequential map of our county.
Thank you. Going to move over to the city of Lubbock, Texas. If someone is talking, you may be on mute.
I think you might have to unmute yourself if possible, or unmute your phone.
I believe they texted a group chat saying they have no mic.
Okay. Give that a moment to see if we can fix this technical issue.
Ethan, this is Allison. I wonder if they may not have access to a microphone. They're saying they have Lieutenant Snodgrass, Officer Crane, and Officer Wilhelm.
Okay.
Which is great. Welcome, everyone. Would it help if we can also refer people to, the document, Rachel, that you wrote up containing everyone's project description. So people can read about each project also, a brief summary as we're going through the introduction. So welcome to Lubbock.
Yes, thank you. And we want to hear you, so hopefully we can figure that out. So we're going to move towards the Colorado Division of Criminal Justice. The city of St. Louis had an emergency and was unable to attend with us today. So Colorado Division of Criminal Justice.
So my name's Peggy Heil, and I think I'm the only one. I scrolled through the boxes. I think I'm the only one from our team that's here today. But we're actually in the Intercept 01 area because we're focused on how to respond to calls to 911 that involve behavioral health crisis. So, and sending mental health resources out rather than just law enforcement.
Thank you, Peggy. So next, we're going to go over to Fort Bend County, Texas.
Hi, let me see if you can see me. Can you hear me?
Again?
Okay, I don't know if you can see me, but should be able to see me, but let me see. Hold on just a second. Well, if you can't see me, I apologize, but I am, oh, you can see me. Thank you, Faye. I'm Dr. Almeida, Connie Almeida, and I'm actually the project director for this project, and I have at least 2 of our team members on the call. Hold on, I think I lost you all, but you can still hear me. Nima Ganga, she is our project coordinator, project manager. Joined the team in end of February or beginning of March. Obviously, then we've had COVID. We've all had to shift resources to help the county health department, and but we're excited to refocus on this project. Also have Faye James, who works for Behavioral Health Services and is providing some technical support for the project. I believe that those are the only 2 individuals from Fort Bend County. If there's others, please let me know, and I apologize if I wasn't aware that you were on. Fort Bend County, so we're a little unique. So we're actually a county department that, you know, I report to Commissioner's Court, but our core business is criminal justice and mental health. So we support the courts, we support the jail. We've been very involved in the development of our CIT team. We have made several, I think, really advances in our system. However, the system continues to be fragmented, and there continues to be an overrepresentation of people with mental illness in the jail. So our focus for this project is really, you know, going back to really understanding who is in the jail, and also, did they get connected to services? Have they, what has been their experience with the service delivery system? And then how can we do a better job at connecting them to the services? So really understanding those mental health and substance abuse needs upon booking, and then diverting them to the appropriate services, but tracking whether they get connected to those services, and what the outcome is of that. So kind of that post-booking, because we have a very strong CIT team. That doesn't mean we don't, you know, we're not focusing on, you know, Intercept 0 and 1, because we work very closely with our health department and social services, a lot of attention to social determinants of health, all those things. But really this focus right now is on that booking, because that's where we feel, that post-booking, that's where we feel like we can have a lot of impact right now. So that's very briefly what we're doing at Fort Bend County.
Thank you. Thank you very much for sharing. So we're going to move over to Kanatsai Indian Tribe.
Ethan, this is Allison again. From the Justice Center. I was looking through the people in attendance. I don't recognize. Sometimes you can't, you know, people call from numbers and you can't tell. But I'm not sure that anyone from that team is on. I know they have a huge time difference. Maybe we can try them again at the end of the list and we can move forward.
Sure.
Unless somebody. Okay, thank you.
Sure, absolutely. So we'll move on to LaFourche Parish Sheriff's Office, Louisiana.
Can everybody hear me?
Yes, I can.
My name is Dr. Dina Williams. I am the Behavioral Health Coordinator at the Lafourche Parish Correctional Complex in Tupelo, Louisiana. I am joined with my colleagues. The whole team is here. We have our programs team here. To my left is Deputy Vernell Talbert. Across the table from me is Ms. Cherry Wilmore. She's our case manager. Mr. Talbert is a program facilitator. Deputy Danielle Finisher is also a program facilitator. And we have Ms. Deborah Guidry, who's also a program facilitator. And right to my right is Ms. Maggie Bro, who is the Assistant Director of Programs for the Lafourche Parish Correctional Complex. And our project or our grant is basically geared toward diversion for persons with mental illness. And the way we're doing it is we are partnering with a local mental health, behavioral health agency called South Central Human Services Authority. And what they're doing is they are providing crisis intervention team training for our local law enforcement officers here in the parish and in the city, as well as surrounding parishes, with the goal of, like I said, diversion and also de-escalation. In addition to the patrol-based crisis intervention team training, we also have done a corrections-based crisis intervention team training with the National Institute of Corrections. And so ultimately what we want to do, once we have done with training, we want to take it a step further and just work with our local judiciary in terms of further diversion and perhaps moving forward and developing mental health court. And who just walked in is our the Corrections Department Head, Major Jeremy Grenier, who's also part of the team.
How you doing?
Hello. Well, thank you. Thank you for the introductions. So we're going to move over to McLean County, Illinois.
Okay. Hi, everyone. My name is Danelle Pressburger, and I am from McLean County. We are in the center part of the state in the Midwest. I'm joined with Corey Tello, who is one of our stakeholders here and part of our project. McLean County Juvenile Court Services and the Center for Youth and Family Solutions is a joint project working with youth up to the ages of 18 who have had involvement with some type of police contact, and getting them services with service providers within our community and doing wraparound services for the children and families. So we are brand new as far as starting our grant. We just ended the planning and implementation guide, and we'll be submitting that to get approval. So happy to be a part of this group. So thank you.
Great, thank you very much. And so next we're going to move on to the Mental Health and Recovery Service Board of Union County, Ohio. I believe that is a typo. I think I'm correct. So Union County.
Hello, this is Mackenzie Poling. I'm the Special Projects Coordinator at the Mental Health Board in Union County, Ohio. I am the only team member on this learning community. We decided to kind of divide and conquer among the different learning communities. And our agency is a little bit different because we don't provide any direct service. So we're really helping with the collaboration between our community agencies. So this is a follow-up grant after the Category 1 planning grant that we had in 2017. And so with this one, we're really focusing on our law enforcement and our jail and courts, and trying to identify some of those individuals in the jail with universal screening tools. Thank you.
Thank you. Next, we're going to move over to the Omaha Police Department, Nebraska.
Can you guys hear us?
Can.
All right, so my name is Deputy Chief Michelle Bang. I oversee our mental health programs for the department. And so I'm here with Lindsay Kroll, our mental health coordinator. She's a licensed mental health practitioner that's works for the Omaha Police Department. And then also on the call is Kristen Lynham, our grant coordinator for the department. So we've been working on this grant for a couple years now. It's mainly, the purpose was to help to expand our CIT programs within the Omaha Police Departments to add mental health first aid training and to basically get more officers, frontline officers, trained in the CIT model. In addition to that, it helped to expand. So we have embedded co-responders that are licensed mental health practitioners that are work out of our 5 precincts. It helped to expand that program. And then what are some other key things? Yes. And then the mental health coordinator position. Oh, CIT coordinator position. So this is, we actually are a consortium of law enforcement, local law enforcement agencies that most of that CIT work, training work had been done by volunteers. They came together cooperatively, found that as we expanded the programs, that work became harder and harder to manage. And so we hired a CIT coordinator to help to facilitate that. So unfortunately, COVID this year is making going to our learning sites and all of the things that you guys are talking about difficult. So, and looking how that model will work. So I'm certain we're not going to hit our target numbers this year, and we'll have to ask for an extension. We also are looking at ways in which we can better connect our consumers to resources so that we can divert away from EPC as well as from incarceration. And that is one of the things that two of the things that we very closely track and trying to get those folks diverted. So we are also working on the Stepping Up initiative with our corrections, our prosecutors, and then we work closely with our mental health community partners to help to facilitate that. So, don't know if you have any other questions. Other than that, that's it in a nutshell.
No, thank you very much. That was very informative. We'll move on next to Pima County, Arizona.
Hi, my name is Dee Dee Avery, and I am with the Community Research Evaluation and Development Team at the University of Arizona. And we are actually the evaluators for the Compass Court, Consolidated Misdemeanor Problem Solving Court that was newly formed. And I believe I'm the only one on the call from our team. I think that our practitioners, our personnel are well versed in trauma-informed practices, and I, as the evaluator, wanted to take this opportunity to learn more.
Great, thank you. Going to move over to Rockingham County, Virginia.
Hi, I'm Denise Janoka, and with me today is our new clinician, Chuck Prater. We are new with our grant. We're still in the training period. We're completing our B&I guide and working on that. COVID has slowed us down as well, but we plan to partner with local law enforcement. We will, with our mental health clinician, we will join with local law enforcement on 911 calls, first response. We also, our goal is to reduce recidivism for female offenders specifically. So we'll be taking calls from the community, also from stakeholders and from our local law enforcement. We plan to also do some short-term case management for and make referrals for therapy or for detox or rehab services. That's our plan. We are a rural community in Virginia, but the city that we are located in, that's part of our county, though it's rural, we are very multicultural, and one of the most multicultural cities actually in the nation. So we have big challenges, but we're excited to get going.
Excellent, thank you. Now we're going to move over to Sacramento, California.
Hi, this is Denise Sinnott. I'm with Sacramento County Public Affairs Office. I actually have 2 grant teams on our grant team, and that's our team. This call is where I am an identify individuals in custody that has mental health issues. Then we go in and we do a need assessment screening on all inmates, and then there's needed for at-risks to figure out community and legal service.
Tiffany, I don't mean to interrupt you. Can you adjust your mic a little bit? It's cutting in and out for people. We're not catching everything you're saying. I'm not sure if it's on your end with mic.
Let me try this. Is that better?
Yes, that's much better.
Okay, yeah, so the pretrial support team grant, we actually have already started launching it in light of all the recent arrests with the George Floyd protests and the COVID issues in custody. So we've been able to already start assessing people, link people to services, and get people out of custody and identify mental health issues. So that's really exciting. Rachel Lee was to allow me to get another group on this call, which is a grant funded through BSCC that I'm leading, and that is for our juvenile trauma court. Because this learning is about trauma, and we're launching a trauma court at our juvenile division. So we identify youth with trauma, we provide assessments, and then we link them to services. So on this call is also my supervisor of the juvenile division, Mark Slaughter, our lead attorney, Patricia Contreras, our 2 social workers involved with that grant, Ali Acevedo and Teresa Cordova, and our 2 attorneys, Nicole Adamoy and David Bell. So we have a whole group of people on this call, and we thank you for letting us all participate.
Well, welcome to you and your team. Thank you. And now we're going to move over to town of Tewksbury, Massachusetts.
Hi, everybody. My name is Matthew Page Shelton. I am the Frontline Initiative Regional Director. And on the call with us today is also Maria Ruggiero, who is our Substance Use Prevention Director, as well as Officer Carrie Bushnell, who's standing in for the police chief for the town of Dracut. And she serves as a mental health officer for us with the town of Dracut. The Frontline Initiative is a Category 3 recipient. We are an expansion project. We're a police mental health collaborative, the lead agency being the town of Tewksbury. However, it is a regional collaboration between 5 local police departments in Northeast Massachusetts. And we are building upon an existing jail diversion, working sort of mostly in Intercept 0 and Intercept 1, and focusing our attentions on pre-arrest diversions and ER diversions, and trying to do more interaction in the community. Focusing our work in 3 main pillars: prevention, crisis response, and then recovery. And we're excited to bring an expanded set of services to the community that that can include things like recovery coaches and peer specialists, as well as our clinical staff through our master's level clinicians in the field. So we're excited to be here and sort of add this to our toolbox. Thanks.
Thank you for being here. Well, thank you all for your introductions. Certainly an exciting group with us today. So looking at our session outline, we're going to begin to move into the content portion, and I'm going to be turning it over to Dr. Callahan to start us off there. As we start off, there are going to be a couple polls that you'll see popping up, and we will go into those. There will be a submit button. Just make sure after you do answer to hit the submit button in order to have the results show up on our end. So Dr. Callahan, I will turn it over to you.
Okay, thank you very much, Ethan, and welcome everybody. I was really interested in hearing who all was going to be on the virtual learning community, and thank you for telling us a little bit more about your program. A couple of points I want to make before I discuss the polling questions is, although we may be speaking to a large extent about the adult criminal justice system and mental health system, the principles of trauma-informed care and trauma-informed practice really cross over all pieces of the criminal and juvenile justice system, as well as the behavioral health systems that support the justice system. So I apologize if we're using primarily adult examples, but at the heart of trauma-informed practice and trauma-informed care, it is the same whether you're treating or responding to a family, a child, or an adult. So I just wanted to make sure, because I know there are a number of people on this learning community who are working primarily in the juvenile system. And I also think I really give you a lot of credit for working to integrate trauma-informed practice at the juvenile level, because when I do any presentation on trauma and the extent of trauma in the adult system, I think it's really important for us to really have a developmental approach. And so the better the juvenile system does at addressing trauma and previous traumas that people have had, the better really that response is going to be able to be, and the more prepared the adult system will be to meet the needs of people. So just wanted to mention that, because when I reviewed all the membership and then heard you today, I wanted to make sure that the people who are working primarily in the juvenile area know that this is as applicable to them, and the better the work you do, the easier the work it is at the adult level. So thank you. We have a couple of poll questions. We just wanted to kind of take a temperature. And the first question is, have you had a sequential intercept mapping in your jurisdiction? And if you could answer yes, no, or not sure, the question should have popped up on your screen right now. I'm not sure where the results are for that, Ethan. Do you know?
They are showing up on my screen. Yep.
Okay. So I don't have it on mine for some reason. So what
they're going on. So Dr. Callahan, this is Allison. So I think they're pretty much finished, but it's to the question, 58% answered yes, they have had a SIN mapping, sequential intercept mapping. 16% have not, and 26% are not sure.
Okay. So for those of you who have had a SIM mapping, I'm sure the framework is something you're really familiar with. And even if you haven't had a mapping, my guess is that you probably have heard about it. It's a language that a lot of strategic planning is organized around, because it is something that really can apply across all communities. So can we have the next polling question, please, Ethan? Okay, the next question is, I think we need the next slide too. Whether or not you have participated in any training on the topic of how to be trauma informed when working with people involved in the criminal justice system. So this could be whether you individually or you as part of your community, a yes or no response. Thank you.
So Lisa, Dr. Callahan, we have 76% said yes, 24% said no.
Okay, great. That's really good news. Thank you. So about 3/4 of you have engaged in trauma-informed training. The other 25% of you, even if you haven't participated in training, I'm sure that it has become part of your working conversation and your working dialogue as you work with people in the justice system. So can we have the next question, please? Or not the next question, the next slide, thank you. Some of you may have participated in the webinar that we had in March, which was really a soup to nuts about becoming trauma informed in your part of the justice system and why it's important. So I'm just, for those of you who were not on that webinar, or maybe don't remember all of the points that we made, I want to just give you a quick overview of that before we jump into really looking at the 0-1 intercept, which is what my colleague Ashley Kreider is going to do. So the first question I always like to address is, why has trauma become a focus in the justice system? Each community probably has its own particular response to that, but overall, there really has been an increase in the introducing trauma into the conversation about how to improve justice practices. That is partly based upon the events that we're living through now and have lived through in the last number of years. It also has been pushed along by the really increased research on the brain and the effect of trauma on the brain. And that is both physical trauma, emotional trauma, psychological trauma. We can credit the researchers who have been really focused on the impact of all different types of trauma on people, not just trauma that they have experienced in childhood, but trauma that they're experiencing currently in their adult lives. And also, as part of that, we've really focused a lot of our attention and our resources toward understanding the trauma that our soldiers have experienced, both combat soldiers and those who maybe didn't serve in combat, but were deployed often multiple times away from their families and away from their communities and their jobs. And what we've come to understand about trauma is it's not something that necessarily is a one-size-fits-all. It affects people very differently. The onset of trauma can be at very different points in time. What may appear to be trauma for you what may not be to the person who is, I would say, sitting next to you, but chances are nobody's sitting next to you right now, but virtually sitting next to you. It's really universal among the people who you are going to encounter in the justice system. And this isn't to dismiss it and mean that it's kind of a watered down version, not at all. Trauma is something that really is very individualized, and it's something that we need to really just meet people where they are and what their understanding of their experiences has been. You may wonder why, what's in it for you, and there are a lot of advantages to being trauma informed, not the least of which is most people go into this work because they want to help people, and becoming trauma informed and having a trauma informed lens as part of the way that you look at a situation really can improve outcomes for not only for the people that you're working with, but also for yourself and for your colleagues. So there's really no cost at being trauma informed. It's not a soft and fuzzy way of approaching people who are involved in the justice system, but it really is a way to make people feel safe, not just you, but also the people with whom you are encountering on a daily basis. The work that we've done, I mentioned it briefly when I talked about PRA, but the work that we do around trauma has largely been funded by the Substance Abuse and Mental Health Services Administration, which is SAMHSA for short, and which is part of the Health and Human Services. And we use their definition of trauma because it really allows for many really broad boundaries of what kinds of incidents, what kind of events might be considered trauma. And I'm going to read it for you as many times as I have said this definition. I still read it to make sure I don't miss any aspects of it. But the SAMHSA definition of trauma, we refer to it as the 3 E's, as the letter E. Individual trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. So it's very important to keep in mind those 3 E's. So it's the event, the experience, and the effect, because for something to be considered a trauma, it has to meet all 3 of those check marks, if you will. Many of us have bad things happen to us, but the way we experience those particular events isn't where we feel as though our life is being threatened or our child's life is being threatened. It's a bad event, but it doesn't have that kind of, our experience of it isn't like we feel as though we've lost complete control of the situation. And even in those circumstances where you feel a bit out of control, if it's not something that lingers with you, that the effects don't permeate every part of your life and don't really change your perspective on the world, then again, that bad event and even that really terrifying experience isn't really considered a trauma. It's those long-lasting effects that finish the definition of a trauma. So it's the event, the experience, and the effects. And speaking of the effects, the simple way to say is that the impact of trauma, the effects of trauma is really, it's pervasive. It hits on every part of a person's life. I'm not going to go into the details, but for example, it affects somebody's sort of their physical or medical well-being. We know from the ACE studies that were first done by Kaiser Permanente and then now by the Centers for Disease Control, we know that people with significant childhood trauma have worse medical outcomes, worse health outcomes as an adult. We don't know that it's causal. The ACEs are not explanations, but they're just an association with poor outcomes as an adult. Trauma, one of the other dimensions of the effects of trauma is in your mental health issues. Some of the symptoms of trauma really might look like mental illness when in fact they may be trauma. So having clinicians who are good diagnosticians and are trauma informed and are trained in trauma practice is really important. Behavioral problems, many times this is what gets them into the criminal justice system, why you know them. Poor relationships, and also substance abuse. Again, this is probably part of the reason why you know someone is because of both their substance abuse and or their behavioral problems. Some people are affected by trauma and others aren't, and that's something that it speaks to a person's resilience and risk factors. That's going to vary from person to person. And as you work with people in the criminal justice, the people who you serve, whether it's clinically or through security, recognizing that we all come in with our own fingerprint, if you will, not just our literal physical fingerprint, but our trauma fingerprint, our own risk factors, our own resilience factors that make our experiences with a bad situation vary from person to person. Okay, the next slide. Okay, SAMHSA's trauma-informed approach is the 4 R's, sort of building on the 3 R's. To have a trauma-informed approach, it's important to realize the prevalence of trauma and why a trauma-informed approach is important. There are many ways of educating yourself or training yourself on that. Recognize also that trauma affects all individuals in an organization, program, system, and workforce. And I want to emphasize here that, for example, vicarious trauma is something that as behavioral health and justice professionals, you are at risk for as you work with people who have significant trauma histories. Learn to respond effectively and with compassion. In other words, having that trauma-informed lens. And ultimately, what the goal is to resist re-traumatizing people. I believe that for the most part, most people who work with people in the justice system do not intentionally re-traumatize somebody. It's by accident. It's not really thinking or diving deeply into what might be re-traumatizing about the work that we do or the language that we use or the tone of voice that we use. And that's really part of the goal of this virtual learning community, is to really drill down. And as you know from the exercise that you were sent, that's really one of the goals, is for us to spend some time really thinking of ways of avoiding re-traumatizing people. Next slide, please. So what's trauma-informed practice? Very simply, it's incorporating an understanding of trauma into your routine practice. That's knowing what trauma is, whether it's primary trauma or whether it's vicarious and secondary trauma. It's assuring that your clients, your defendants with whom you work, and their families have access to trauma-informed interventions. And this is really important for you to have an inventory, if you will, and an understanding of what services exist in your community. Just because something says that it's a trauma-informed practice or a trauma-informed agency, if you are going to be referring people there and you're going to be relying on them to be part of your stakeholder group in becoming more trauma-informed, you need to do your homework and make sure that in fact they are delivering trauma-informed practices in a trauma-informed way. And this, I always emphasize, it's important in your organization. The receptionist needs to be trauma-informed, not just your clinical professionals, not just your security professionals, but that first person who answers the phone or greets someone when they walk in the door. If you have security at your community provider agencies, those security officers need to be trauma-informed. If someone is approaching your agency and the person on the other end of the phone or through the glass when they come for the first time responds in a way that is not very trauma-informed and is very impatient, that person's going to turn around and walk away, and you've really lost an opportunity. So everyone in your organization needs to be trauma-informed, not just the professionals. And this is also true across all of your partner organizations, and that's what we're going to really spend a lot of time talking about during this virtual learning community across the four meetings. Next slide, please. So incorporating trauma-informed practices into your work, just some basic guidelines, making sure you have practices in place that identify trauma. If you're not a clinician, making sure the clinicians with whom you work identify trauma, and we'll talk about some ways to do that. Adjusting the relationships that you have with the people with whom you work. We talk about in our trauma training that risk, R-I-S-C, reduces risk, R-I-S-K. Making sure that people are given information, they're shown respect, that they feel safe. And what we know is that someone who has a trauma history, until they feel safe, anything that you do, any approaches that you have are really going to be resisted because they don't feel safe, emotionally and physically safe. And lastly, offering choice where you can. Sometimes we think that in the criminal justice system, there's very little choice. In our experience in doing this training with many, many law enforcement officers and corrections officers, there is room for choice. There are a lot of ways you can introduce choice into your practice, your own personal practice. And one thing we know is that people who have significant trauma histories, they talk a lot about never having control. They don't have control over what happens to their bodies. They don't have control what happens to their money. They don't have control what happens to their children, to their housing. So by giving people a choice, even if it's a little choice, like what radio station do you want to listen to when I have to transport you to the jail, that is something that can be done. There's no cost to doing that. And it can give someone a little bit of a sense of control over their environment. We also really want you to focus on ways of not just changing your organization, but changing your own habits. I like this phrase. I will attribute it to whoever came up with it. I don't know who that is, but authority is not based on power. It's based on trust. And until you have the trust of the people you're working with, your authority doesn't make any difference to them. Whether you're wearing a uniform or not, whether you have a white coat on or a black robe on or a stethoscope or a badge, until they trust you, your authority really isn't going to be very persuasive with them, especially if they have a significant trauma history. And lastly is preventing vicarious trauma for you and your colleagues. And this is a really important part of becoming trauma informed. There are a number of people who specialize in bringing awareness of secondary and vicarious trauma. It's not the same as burnout. I think we're all feeling really burnout right now with all the virtual work that we're doing. It's not that kind of emotional exhaustion. Vicarious trauma is developing the same symptoms as though you personally experienced the trauma of others with whom you work. So preventing vicarious trauma in your workplaces is a key component of being a trauma-informed workplace. Next slide, please. Okay, so the 10 implementation domains. I'm going to go over these very quickly because I want to get into the meat of this, which is talking about Intercept 0 and 1. Some of these you have more or less control over depending upon where you are in the power hierarchy. But the first really necessary component to becoming a trauma-informed organization, regardless of where you are across the SIM, is governance and leadership. You need a champion. You need a champion who actually, when they call a meeting, people show up. So often that's the judge, that's the sheriff, that's the head of the behavioral health system, it's the head of the mayor's task force on becoming a trauma-informed community. It's someone who actually has the chops, and people will show up. People answer their calls, people come to those meetings. Now, a little bit later, they can hand that off to someone, but in the convening of this and changing the way in which you're going to do, not only personally, but organizationally, you're going to work, requires leadership. The second thing is to examine your policies, and that's what the exercise that we're going to have as part of today is important. You really need to dive deeply into that. Some of the things that we've done in the past, we thought we had to do, and in examining it, we realized that we don't have to do. It's just the way we've always done things. So, and some of those things are very, very re-traumatizing for people. The physical environment. I was doing a trauma train the trainer the other day, and this doesn't happen very often because we don't get a chance to revisit the communities often that we train. We don't get a chance to revisit, but I had done a trauma-informed courts presentation at the Montana State Court Conference, Treatment Court Conference 2018. And one of the people who had attended that told me that after the presentation, the judge and he, for whom he was the court coordinator, decided to change the environment around their treatment court. The judge came down off the dais, took off his robe, and sat down at the table now with the people who are participating in this drug court. And they talked about what a different environment that was, and how people were much more relaxed and much more engaged than they had been before when it was set up as a traditional court. Lots of ways to examine your physical environment. Engagement, involvement. I was happy to hear a number of you are talking about engaging recovery coaches, peers, I would say also families, working with other organizations in your community, such as NAMI and other organizations who can ask them what it's like to be arrested and go through the booking process. Just ask somebody who's gone through that. Ask them how that feels, what the different stages are. Not that you can change all of them, but you can at least be informed about how they may be re-traumatizing, how it may be, there may be places where you can tweak that a little bit. Screening and assessment and treatment services. We have lots of resources available to you, which I just let me know and I can make sure that you get those. Making sure that you use evidence-based screens and assessments and access evidence-based treatment services on trauma. Cross-sector collaboration, that's what all this is about. For those of you who work in the juvenile system, you have more collaborators. There's just the juvenile system is, in some respects, looks a little simpler because the process may be a little simpler, but you have so many more agencies that you need to engage to be trauma informed, such as the schools. That's a really necessary component for your organization to be trauma informed. Training and workforce development. It needs to be part of your regular training and workforce. New people onboarding, make sure that they get the trauma training and they understand that this is a priority for your organization. These last three are really, they're really the big 35,000 foot goals, and we could talk about those at a later time, but it's making sure that you have built into your mission statement, into your funding, into your organization, a way to make sure that you are in fact doing what you intend to be doing in terms of becoming trauma informed. Partnering with a university or college in your community. I know there's a couple of evaluators on here. That's a great way to take advantage of the experts in your area to make sure that you're measuring what you mean to be measuring and that you are in fact making progress in the direction that you intend to be. Next slide, please. Okay, so quickly, and this is what again is the foundation for the activity. The later in this day's work, analyzing your policies to determine if they're trauma informed. Make sure that you develop policies and procedures and not make it just personal. Okay, because if you leave, if it's not part of the policies and procedures, it's going to leave with you. So making sure that it's really hardwired into your policies and procedures and into your organization and into your community, not just it's your way of being better at your job, but also that it becomes hardwired into your organization. Next slide, please. So this is an outline of where we're going across the 4 meetings. The first is obviously focusing on Intercepts 0 and 1, which is community and law enforcement, and Ashley Kreider, who has done a lot of work in this Intercept 0 and 1, is here to talk today about that. Intercepts 2 and 3 will be about initial detention and pretrial. Dan Abreu is joining me on that to discuss Intercepts 2 and 3. Many of you probably know Dan. Some people call him Mr. Sim. He's probably done more sequential intercept mappings than anyone else in the United States, and probably of many people combined. He's a clinician by training and has a lot of real world experience to bring. And then for Intercepts 4 and 5, Maggie Morales is joining me. She is head of probation and reentry for El Paso County, Texas. And she also is a trained clinician, and she will be joining us for the 4-5 Intercept exercises.
Is that just me or?
Can people hear me? Are we back on?
Lisa, we lost you for
yeah, I'm back on.
So
am I back on?
I can hear you.
I can't hear you.
I can hear you, Lisa.
Okay.
So I just want to double check. Can someone out in the grant from the grant teams just say if they're back on?
Yeah, they said that now you're back.
Okay. Okay.
Hey.
Okay. I think we just left off where you were describing Maggie Morales. Maybe you could start there. Yeah.
Sure. So for Intercept 4-5, Maggie Morales will be joining us for that VLC meeting. She is head of probation for El Paso County in Texas. She's also a member of the APPA board, and she is one of our trauma trainers as well. So she'll be here for the 4-5 Intercept discussion. Next slide, please. So the guiding objectives then for all three of the sessions, the fourth we're going to talk about later, and as Ethan mentioned, it's to identify policies, procedures, and practices that run the risk of re-traumatizing a person with a trauma history, and also to avoid traumatizing people to start with. Identify opportunities for discretion in implementing those directives, and identifying modifications to be more trauma informed. Next slide, please. Becoming trauma informed is reciprocal. It's not just what you do, it's how you do it and how the people you are working with respond to it. And that in itself feeds back into your organization. And that reinforces and gives us feedback into whether the work we're doing, whether the organization is in fact meeting the goals of becoming more trauma informed. So it is a reciprocal relationship between the provider and the community, and then back to the provider again. Next slide, please. I keep thinking I'm going to click. There we go. Okay, at this point, I'd like to turn the microphone over to Ashley Kreider, and she will start with the discussion of the sequential intercept model.
Sure, so if we can just back up a slide, actually. It sounds like there's a fair amount of familiarity with the SIM model with folks on the phone, so I won't spend too much time, but I do think it's important to touch on some best practices in Intercept 0 and 1 and talk about how they can relate to the issue of trauma and being trauma informed. So a little bit of history, the SIM model, which is what the SIM workshop is based on, was developed in the early 2000s by a forensic psychologist and forensic psychiatrist. And it was first tested in Summit County, Ohio, and Southeast Pennsylvania. So there are two resources on your screen. If you're a little bit of a data nerd and want to dive into the history, there's an article in Psychiatric Services, and then a book that was later written really describing the basis and the history of the model itself. So all of that to say, the sequential intercept model, and you'll see the image of the model in the next slide, helps to assist communities in really identifying where their gaps in resources are. And the basis behind that is that people move through the justice system in at least semi-predictable ways. So maybe not totally linear, but more or less when we're looking at the adult system, we can draw some generalities about what happens. So as I said, when we use the model, we're talking about where can folks be diverted when appropriate from the justice system into treatment, into community alternatives, diversion, things like that. Next slide, please. So this is the sequential intercept model in its current form. Intercept 0 was actually added most recently in the fall of 2017, and I'll speak to that a little bit in just a second. You'll notice there are some different sets of arrows here. Most of them go towards the right side of your screen, kind of penetrating further through the justice system, but there are some that have back and forth arrows. So that is to signify that folks may move back and forth. So the clearest example of this probably is a parole or probation violation where folks are cycling back into the system. So you can almost kind of take this piece of paper if it was printed out and move it into a circle in some cases, unfortunately, for folks. Again, the main crux of using this model is to try to build off-ramps out of the justice system and into the community, and that can happen at really any intercept. When we do the workshop, we talk about the potential in each of these intercepts. Probably most commonly, we're talking about diversion pre-intercept 1, so it bleeds a little bit back and forth between 0 and 1 prior to an arrest. Also at the pre-trial stage, if folks can be released on pre-trial supervision, and then obviously there are a lot of options at the sentencing phase. So in addition to mapping a system using this model, we talk about the facts that people with behavioral health needs and behavioral health disorders get stuck. We know that they spend longer time in jail and prison than their counterparts. The issue of trauma, it could kind of be another layer on top of this model. As Lisa said, being able to not re-traumatize folks as they move through these different intercepts is something that we talk a lot about. And then also certainly talking about disparities with people of color and how much they're represented as we move through the justice system is a huge focus of this. Next slide, please. So Intercept 0, as I said, was our most recent intercept to be kind of formally defined. Prior to that, we certainly talked about the dual role of law enforcement, if you will, on the community side of Intercept 0, and then as the, there's a guardian versus warrior kind of, I would say not two sides of the coin, that's probably too oppositional, but certainly a dual role when we're looking at 0 and 1. So we talked about a lot of those issues, but it really became clear that we needed to have Intercept 0 as a standalone intercept in order to talk about other alternatives in this kind of crisis care continuum that doesn't necessarily have to involve law enforcement when not needed. Next slide, please. So there are a host of options and different programs within this continuum of crisis services. I won't go into a lot of detail, but I imagine there are pieces of them across all of your jurisdictions. And they serve different needs, different populations, different lengths of time, certainly, and often come from different funding streams. So there are a lot of options to consider based on folks' needs. Again, knowing your population and the people that you're serving most often is really important here. And there are a lot of challenges which we acknowledge. Even if there are some of these options in your community, what is their capacity like? What is their bed space that's available if they're have beds to offer? What are wait times for law enforcement if we're asking them to do a drop-off? Things like that. So there are a couple of resources, there are many, but a couple that we usually like to talk about as far as this continuum of crisis services. SAMHSA has put out a lot of publications, and then there's also a resource called Crisis Now, which can allow communities to kind of walk them through an assessment of what your continuum looks like locally. Next slide, please. So Intercept 1, we know that sometimes it's unavoidable, to have contact with law enforcement. When we deliver this workshop around the country, we often ask the room, how many of you went into law enforcement because you wanted to be the first person on scene when someone's experiencing a behavioral health crisis? And I have yet to see a hand go up. But we know that law enforcement are often first responders, that they're put in these situations, sometimes with training and sometimes with not. So it's important to, again, look at these kind of dual roles across 0 and 1 and see how we can support law enforcement. Next slide, please. One of the, some of the best practices and one of the things we talk about early on in this section of the SIM is 911 and dispatch. So does dispatch ask any questions as far as mental health needs or issues that might come in contact with the person who's calling? Are they using a mental health script? Is that information getting passed on to the responding officer when it's helpful? Obviously, considering HIPAA and all of that, but there are a lot of ways that communities have implemented policies and procedures to help out law enforcement in these situations, or to allow folks to respond that are especially trained in behavioral health when that's appropriate and may not need a law enforcement response. There is CIT, crisis intervention team training for dispatch officers. It's not only for law enforcement and correctional officers, but it's also available at the dispatch stage. In many jurisdictions, the 911 dispatch office has the ability to transfer calls to crisis lines, mental health crisis lines, if it's not an emergency situation or one that warrants a law enforcement response. So that's something that folks may want more information about. Next slide, please. Again, several models for law enforcement response that can involve behavioral health professionals at different levels. We mentioned CIT. I imagine most folks on the phone are familiar. It's a 40-hour training program that in some jurisdictions, they have had entire departments trained, and in others, they've developed a specialized team of CIT officers that are available to respond. And then there's different kind of theory behind doing each of those. In addition to CIT, there's a co-responder model, which is, again, pretty commonly known, although it can look very different depending on the jurisdiction and your capacity for services. There's a resource at the end of my few slides that speaks in more depth to the co-responder model and what's possible there. Typically, that's law enforcement responding with behavioral health professionals, sometimes in the same car, sometimes not, and obviously providing assistance to folks with behavioral health needs. Mobile mental health response teams are very similar, although they typically don't involve law enforcement. So maybe it's a separate team that law enforcement can call to respond to a scene that doesn't, again, warrant an arrest or anything like that. Peer staff or consumers are often involved in this type of response. So integrating people with lived experience has a lot of data behind efficacy and help at this stage in particular. So that's something to consider as far as response model. Virtual or offsite support probably is bigger than ever right now due to the COVID pandemic. I know that some of the co-responder teams in some jurisdictions have now transitioned to having folks be totally virtual, where an officer can use an iPad or some kind of other virtual technology to allow a clinician to speak to the person on the ground and do some triaging and help suss out what their needs are. And then all of these options can include other partners like EMS, fire departments, and that can look a little bit more formal or less formal depending, again, on the jurisdiction. Next slide. So there are a lot of, as you can hear, there are a lot of layers to this. Even as we look at the simplicity of 0 and 1, there are a lot of layers of depth that we can go and a lot of points within these two intercepts to have some best practices that can be trauma informed. So there are some additional questions on here as far as making the officer's job as easy as possible and giving them all the tools that we can in their toolbox to respond to folks in a behavioral health crisis. So that's training, that's again, information from dispatch, whether a CIT officer is available, someone with more de-escalation training, things like that. Next slide. So obviously at Intercept 0 and 1, we talk a lot about law enforcement, but I think Lisa mentioned this earlier, the divert to what question is really key. So we might have the best meaning law enforcement department around, and they might have, total willingness to do some of these diversionary options. But if there isn't community capacity, if there isn't some place for them to transport folks, will they be safe? Then systems change is not going to happen. So kind of considering the two prongs of this when we're talking about Intercept 0 and 1, both law enforcement response, first responders, and then also the community capacity and what kind of options are available. That could be a robust crisis stabilization unit, facility, that could be just these mobile response teams. It could include many of these options. So that's, again, why we're talking about a continuum of crisis response. Next slide. So this is the last slide, and it's that co-responder model issue brief that I mentioned earlier. You should be able to click on it, and I'll put the link in the chat box also. But it outlines, gives a little bit of history of the co-responder model as a best practice, outlines the different variations of how it can look in different communities, and then has some information as far as funding, sustainability, things like that. So as we talk about a lot of these best practices, I think the tie-in that we want to make here is that communities could have many of these things that we're touting as ideal, as best practices, that there are data behind, but they may not be trauma informed. So just because communities can check off a lot of these programs doesn't necessarily mean that they're all operating with trauma informed policies and procedures. So something to consider. And then the flip side of that is you don't necessarily need all of these things to check all these boxes of different programs to be a trauma-informed agency or community at a larger level. So you can really start where you are and with what you have available in your jurisdiction and still consider these trauma-informed principles in moving forward. Thank you, and I'll turn it back to the CSG.
Thank you, Ashley and Dr. Callahan, for that. So I'd like to turn us over to the discussion portion of the learning community. And we did have some prepared questions, and I apologize for not mentioning this earlier. That certainly, as things are coming up during the presentation, please chat them in. We are tracking those as they come in. So what I wanted to do, I thought would be a good idea now that people have gone through some of the content, is to sort of just open it up to the group first to see what has come up for folks out there. And have any questions for Ashley or Dr. Callahan at this point. And I can certainly try to just kick it off. I know we did receive a question. I believe it was a question. I'm not sure if it was being presented more as just pointing out, but I think it's certainly something to bring up now, which is racism as a public health issue and that leading to trauma. And so I know the person who put it out, his name is Corey. And so if there was anything additional to that, or Dr. Callahan or Ashley, you'd like to speak to that, that would be great.
Hi, I'm Corey. I'm on my county's public health department, their board, and the state public health organizations, you know, in light of the George Floyd horrendous murder, came out with statements that were much more strongly worded than ever before, that really, you know, declared racism and discrimination as a public health crisis. And it clearly, if you, I mean, everything you talk about with trauma, the 3 E's, I mean, if you have lived with discrimination your entire being, you definitely have trauma. And, you know, really calling all of us to think about, and then trauma, of course, if you also look at the social determinants of health, and again, how everything related to discrimination, how it impacts all of those things that are social determinants like education and housing and employment. And so anyway, it's just been a real reawakening, I think, for me to think about how trauma and racism intersect so much, and how we need to build that into everything we're doing too, in terms of being even more sensitive to that, and really, as we analyze our policies and our procedures, to really think about how that weaves into everything.
Yeah, this is Lisa speaking. I thank you for that, Corey. I think that it's, you know, in preparing for this webinar and in this learning community and talking over the last couple of weeks with all the events as they're unfolding, I think that it provides more people with an understanding of how built in, not just into our justice system, but certainly into our behavioral health system as well. Access to treatment, access to culturally competent treatment is a real concern in all of our communities, and something we've been told over and over again, right? But it seems as though that not enough people are listening at the right time. And at the same time, I think that it's, you know, for those of you or us who are sort of research nerds and like to look at the data and look at the evidence, there's ample evidence that the impact of discrimination, not just in individually, but across communities and across families, really does take takes a toll physically on people as well, in terms of shortening lifespan, not to mention accessing services to treat the medical impact of that. So I think that it is with some humility, we all need to turn our eyes into what we do, both personally in our practice and across the organization, and start with the point of view that there's a lot that we're doing that is making things worse, not intentionally, but I would just argue that, but it's really a necessary exercise to step back and think about how the policies and sometimes it's just small tweaks that can be done. It's hiring practices, it's it's training, it's maintaining, it's supporting, it's recognizing, as I said, the vicarious trauma for people who work in the areas that intersect between the justice system. So I think that it is a public health crisis, and I hope that we're recognizing that on a larger level. We were talking earlier today also how whether anything comes of it, I don't know, but the president signed an executive order yesterday that would provide funding for clinicians to be more deeply involved in responding to incidents, crises in communities. How that gets implemented is unknown, but it was at least given an acknowledgement that there are many circumstances and situations that not only do the police would prefer not to respond to, I mean, that it's outside of what their mission is. As Ashley said, how many people, you know, when you're doing a CIT training, if you ask them how many people went into policing so they could respond to people in a crisis, a behavioral health crisis, no one raises their hand. So taking that, really taking that seriously. And so I think that we'll see if that becomes, you know, if it has legs, so to speak.
Thank you. And I think LaForge Parish would like to comment on this.
Yes, sir. I was just thinking as you were speaking about what a great time it is for this trauma event. Well, to be more informed about trauma, I was just thinking back, we recently had 2 murders in a community, I guess we would call it a high crime community. And just the cycle of violence as far as seeing 2 young ladies being killed and nobody wanted to speak on it, and how that trauma would affect others in the community. And is at that point to where the people in the community, I guess they lost faith in law enforcement at some point. So they're suffering from trauma on that end. And it's almost seemed like it's just going to be a never-ending cycle because nobody will want to come forward to speak on it. It empowers criminals to do it again, causing more trauma with people. So if you have that cycle, how can you break it in a sense if, you know, there's no trust in the people that's supposed to protect you, and the criminals just constantly causing more trauma. And then when you deal with the innocent bystanders, you know how they say hurt people hurt people. Mm-hmm. So how I'm guessing, how can we fix that to a certain extent? I guess that's my question for us. And I can go for anybody, you know. It's I didn't ask any specific, but how can we fix that when you have that constant cycle of trauma and violence?
Yeah, I think that's a great question to pose to the group. And please, anyone feel free to chime in and give their input here. Dr. Callahan, Allison, anything you'd like to say to begin on that?
Well, I would say, I think there are multiple approaches that can be taken. What we're doing right here is one approach. Becoming more aware and educating ourselves on what trauma is, what it looks like. Also, for those individuals who are not aware of what racism looks like, really taking an examination and looking at it, examining white privilege, and seeing how those types of things have an impact. And so also what we're doing and talking about policy changes. So when we talk about policy changes, when we're thinking about systemic racism, that's another approach. I feel like there are so many different angles that have to be looked at in order to break the cycle and truly get to the root of the issue.
Yeah, I certainly agree with you. I think this is gonna be a very, very, I think, long process, because I think there are many things that we have to get through. One is certainly looking at the issues that are really very much in front of us in a different way now, which is looking at racism in our institutions. But back to the gentleman's point about, well, how do you address the crime in our neighborhood? And I think there has to be at some point coming back around to rebuilding trust between police departments and their communities. And so whether, you know, going down a trauma-informed path is one way to get there, you know, it's one idea. You know, I think too, it's people need to also go back and have a needs or an evaluation of their communities and sort of say what's most pressing and what can we address today and what's going to take, you know, months, years longer to address. So.
Hi, it's Corey again. One of the cities near where I live, Bloomington, Illinois, they created, and I know lots of places have this, but they did recently create a safety, public safety and kind of a community relations board where now, many of police interactions, if a citizen has a concern about some police related incident that does not get resolved in a way that seems justifiable and with justice, then those incidences a citizen can ask for those incidences to be reviewed before this board. And the board is a very diverse and very objective group, and that has helped build some trust and really caused lots of examination of how things are done. And there hasn't been, lots and lots and lots of them brought, but the ones that have been brought have been very meaningfully engaged in, and they've also, made sure that they hold them in places that are easily accessible to the people that might well be the victims and all of that kind of thing. So they kind of did, without them even, I think, knowing it, put a trauma lens to how they set it up.
I think the gentleman was speaking to something that whenever I listen to and hear talks from people who treat people clinically, are working with people who have significant trauma, one of the first concerns is that concern about safety. Safety and trust have to both be there. Many of our institutions, not just in the justice system, but beyond, have lost their authority because they are not a place that people trust any longer and no longer feel safe there or with their children there or the like. And I think how that gets built up from the community up is really a monumental task. And I think it's one that it has to be started at the community. Obviously, there has to be that cross-community, that cross-collaboration. And when we talk about that, we're not speaking really just about, and definitely not talking about just the agencies or just the official organizations, but the people with lived experience, the people who live in communities that are experiencing the most, whether it's retaliation or lack of resources devoted to those communities, have to really be in the driver's seat to define, what is that experience like? And that's something that some people are very skillful at leading those kind of meaningful conversations and change. But I don't believe it, and that's just I'm stepping outside of my, I just don't think that can go from the top down. I think the resources have to come from obviously the top down, but even defining what the problem is needs to happen. It has to happen organically from the community.
So would it be safe to say that could you have a whole population in these areas suffering from PTSD?
Yeah, absolutely.
So one of the things that we've done at the Omaha Police Department, and a lot of credit goes to, our chief. So when you say it doesn't come from the top down, but he drives the police department, he sets the culture for the police department. So we actually have a weekly meeting with, it's called the Empowerment Network. So it's it's open to any member of the community. The media is there, people from our educational, our public school systems, our local colleges are there, faith-based leaders are there, many of the nonprofit organizations are there, neighborhood watch groups, anybody can come to this meeting. And as part of that meeting, there's a lot of transparency that happens. So this is mainly for our African-American, we're our predominantly African-American community, and it's got it's quite a bit of diversity. A lot of our immigrants live in that area too. and there's some lower socioeconomic factors, so that what you're just describing there, we have in that same community. There is a lot of trauma because that's where a vast majority of our shots fired, our felony assaults, our gun violence, all of that violent crime is happening in that area. And this has taken years to build up. So every week our police department presents real information about what is happening in that area. So we go over the shots fired, we go over arrests, we go over high profile, it's at a very high level. I mean, obviously we're not giving investigative information so that we're not damaging the potential to, solve the crimes, so that they are aware of what is happening and we're sharing that. And then as we also then are listening to the community and some of the things that they are doing, and then that becomes a measure of success. And so our gang unit also works very, very closely with a lot of nonprofits and a lot of these initiatives to try to drive those young people into, those programs to try to alleviate that. So we have gang liaison, which are non-sworn members of the police department. They actually work for our boys and girls clubs. That we partner with. So we do a lot of that front end work, and it's taken a lot of years. So I worked in homicide in the days when nobody wanted to talk, when literally a person was murdered and nobody even called 911. And I can tell you, there's some technology things that make solving crime easier, but we also have quite a bit more partnerships. So, but there's a lot of work that went into that. So that's you've got to front end that to get that trust built back up. Mm-hmm.
Thank you for sharing that. Any other teams that wanted to give input or perspective on this discussion?
This is Allison from the Justice Center. I was just thinking that, again, I don't have any solutions, and I appreciate all the issues that have been raised. It's very complex. I agree. I think it's going to take a lot of time, a lot of effort consistently, right? And to not give up and to keep trying to work through these issues. And we have a moment in time. What struck me when the original gentleman from LaFourche spoke, you mentioned that no one wanted to speak about the issues, the murders that had happened, the crimes that had happened. And so that really struck me as, if you think about the trauma-informed, the principles around trauma-informed, being trauma-informed in your response, one of them is giving voice to things, and so being able to start the conversations and to, as challenging as it can be, to try to have a venue for discussion of what happened and eventually building up trust to get to ideas and solutions. So that just struck me as something that's connected to being trauma informed in general, and I just wanted to add that comment.
Thank you, Allison. So we had a couple other, some other discussion questions here. So thinking about law enforcement, if people could talk about, I think we're all curious to hear what options law enforcement in your community have when responding to a call with a person with mental illness or co-occurring substance use needs who may have a trauma history. And I know we've talked about CIT trained officers and Ashley talked about a co-response model, but curious, what folks have currently in their jurisdiction and community.
Hello, can you hear me?
Yes, go ahead. Yep, I can.
Hi, this is Connie Almeida in Fort Bend County. So we've been developing our CIT team for the last several years. We were actually very fortunate. Our CIT actually was originally funded through the Center of Medicaid Services. So we actually built it as a integrated into a healthcare response system to divert people not only from the jail, but from the emergency room. Of course, the partnership with our local community mental health center is critical. But, you know, we don't have that model where the ride-alongs, you know, and, you know, there are several communities where actually a mental health mental health professional with this law enforcement go out together. We don't have that. And we've looked at that model and sort of capacity issues and resources. I have heard of other communities where they're, again, using the telehealth model. You know, and so obviously we've all become a lot more efficient with this. And because of COVID, which I believe is something we can leverage, you know, how do we use that technology? We have limited mental health professionals, you know, but again, there are some communities where they're using, you know, iPads, whatever technology that they have, so that they have the virtual access to the mental health professionals. So I'd love to, we're not doing that. You know, it's sort of it's kind of on the planning, you know, would love to get there, but I'd love to hear if anybody has been doing that.
So if there's anyone would like to share on that.
Oh, so this is Michelle with OPD again. So Omaha Police. So for us, we have a lot of robust options. The problem is capacity. And so, and now that we have so like the co-responders and things like that in place, our officers are not, you know, they're not used to accessing some of that because for so long there were no resources. So our co-responders are getting used quite a bit. The crisis response team, which are the therapists that are available, you know, the 24/7, they could probably be utilized more. Some of the issues is time to get to call. And then again, just it's about capacity. So we end up probably putting some folks in our emergency departments that really shouldn't be there. And we're working on that, but that is one of our biggest issues.
Ethan, I know that we have other grantees who are not on this learning community call, but we definitely have other JMHCP grantees around the country that are using telehealth more and more. Some of them have, of course, you know, primarily it's the behavioral health partners who are initiating that use in the co-responder teams or in other ways, whether it's in facility programming used for specialty courts. They're using them as the behavioral health provider to be able to continue with services, at least remotely during this time. So we're seeing a lot of use of telehealth around the country. And I think, again, the behavioral health partners are often taking the lead because they're, you know, working on the HIPAA compliance aspects of that. And they may have already had some telehealth capacity in certain communities, particularly really rural ones. So they already have that, you know, luckily have that set up, but many other grantees have been using it. It's a lot of them have accessed some of the emergency COVID funding that is out there. I think, I'm not sure if the Bureau of Justice Assistance had a solicitation open for several months now. And I have to say, I have to look up the date to see if it's still open, but some grantees have applied for that, for funding for specific resources in that way too.
Yeah, Allison, there's a ton of funding that's become available since COVID, on the federal level primarily, but also from private insurers to develop telehealth responses. And that can include just telephone too. If you're serving folks that don't have internet capacity and smartphones and things like that, there's a lot of increased funding and increased, I guess, flexibility, for lack of a better word, on concerns as far as privacy. Obviously, there's still an issue, but there's an understanding that there's a huge need for that right now, and I think some flexibility as far as how to implement it.
This is Charity from Chatham County, and we have been working along with another grant in our community to bring on ride-alongs with clinicians with the local police. And due to COVID, it kind of had to stop a little bit. But hopefully that will be ramping up again. The grant is through the Criminal Justice Coordination Council of Behavioral Health Unit. And we currently are actually opening up a behavioral crisis unit this week. Well, the ribbon cutting is going to be this week. So those are kind of the things that we have been working on here in Chatham County at the Intercepts Zero. So implement training, ECIT for law enforcement throughout the county. And then we're implementing the ride-alongs with our behavioral health community providers and the crisis center that we will be opening up. This will give an alternative for law enforcement to be able to divert people to those places and getting them the correct care that they need. As well as we're looking at, we actually are going to be moving forward with some informational sharing for EMTs to be able to, when they go on site, to be able to pull up, because it'll be HIPAA, making sure we're with HIPAA, so the EMTs, medical providers, will be able to look up the individual and perhaps get them connected to the right services that they need before any type of law enforcement has to get involved.
I think you emphasize one of the stumbling blocks a lot of communities will cite is the information sharing piece of that. When you have behavioral health and the justice system interacting, and that's another level of that trust, right? That it won't be used for purposes other than to get the person help. And when we've done ride-alongs with police officers, Ashley and I both have been involved in a study in Washington State. And probably one of the biggest frustrations that many of the officers have expressed is that they don't have access to not the treatment details. They don't really want to know that, but even to know whether or not someone has a case manager, if someone is on their, is already known to the community provider, that's something that they find they're very frustrated by, that's just not information that they can easily access. So getting over that, succumbing together with some kind of data sharing agreements. And I know that was on that was the goal with some of the grantees, is coming up with those data sharing agreements, like what can you share and how quickly can you share it. And at the very least, for many officers, I would expect they would just like to connect the person with their case manager and drop them off at a safe place where the case manager can pick up. It's not really a law enforcement issue. So I think that'd be something that is really important.
Yes, here in Chatham County, we've encountered, some of the struggle with that. And as we've been working through the grant and our project, we have gotten some connections. And our next, we'll be looking at some of our business, mental health providers being able to, provide and share information with us. But it's getting that trust of, we're not just giving out the information, and building a more business partnership and policies and procedures in that particular way.
Hi, this is Matthew, Tewksbury, town of Tewksbury, and we are, we started off as a co-responder model, and we have done co-response for the last couple of years in partnership with our behavioral health partner. And we are currently working with the Middlesex County Sheriff's Office through their Data-Driven Justice Project, and working on, we're piloting an application called the Care app that shares information. It sort of collects information around sort of what we're discussing here about a person that they're encountering with mental health, and sort of if they have a caseworker that should be notified or a particular person that should be notified, to make sure that we can provide them services on scene. Currently, we are at the point where we're working with the behavioral health partner around data sharing, but the information, we have it sort of separated. So officers are inputting some information and clinicians are inputting some information, and they only have access to their individual sides. They can't see both until we sort of are able to come to an agreement on data sharing. But we're trying, as a part of this grant, we're trying to move in that direction because we really do see the need for that as well. So it's definitely something that we see as an important piece in this puzzle.
So Matthew, is that something proprietary that Middlesex County developed, or did they get it from another place?
They worked with Open Lattice out in California to develop it. I believe it's something that they've been using in other parts of the country with other police departments. And then we've been just modifying the application to sort of make it suit more of our needs here in the county.
Thank you. That's really excellent information. Thank you for that.
Thank you, Matt. So I'm just keeping an eye on our time, and we have a few more things to get through, but I don't want to cut the discussion off. If there are more things that people want to share, we can certainly designate a few more minutes to it.
Ethan, I think there's a question here too about if anyone is familiar with, I'm not sure that I'm pronouncing this correctly, Julata or Hulata for data sharing of first responders. I don't know if anyone's heard of that, or JULOTA. They chatted it in, so people can also respond by chat. I guess I'm thinking too, a lot of the initiatives I think are fantastic, that are the pilots, et cetera, the strategies that people have described are great. Some take a lot of time and effort. Certainly try to pursue those, of course, but I'm thinking, Dr. Callahan, about what you suggested earlier on about how even a simple action that doesn't even necessarily cost anything can help in being more trauma informed. I'm thinking back to, for example, this is not an Intercept 01, but maybe it could be applied to Intercept 01. I worked with a grantee here in New York City, a correctional facility, and they were using mental health first aid, training some of their officers to be like basically co-response teams, but inside the jail to respond to specific areas where there are behavioral health crises and try to help de-escalate and facilitate things. And there are definitely situations where they tried fairly concrete strategies that had big impacts. So for example, a common time when people would get really anxious and worked up is when they had to go to court, right? So they were being transported from jail to go to the court, and they didn't know what was going to happen. They were worried, etc. If their case was ongoing. And so they often wanted to maybe speak to someone, and it wasn't the time when they could access the phone, or they weren't in a place where they could access a phone, etc. But they were very anxious. And so sometimes the team was able to, after trying other techniques of verbal de-escalation, they were able to actually take the person to go and make a phone call to their relative just to get a little bit of support before they had a difficult day in court coming up. And the response was almost instantaneous, right? The person calmed down, they proceeded, the area where they were waiting wasn't disrupted any longer, et cetera, et cetera. And so was struck by that, and perhaps there's other examples that apply to Intercept 0 and 1 that are cost-free ways that you can increase your capacity to be trauma informed.
Thanks.
Without having to apply for a grant necessarily. Yeah.
Thank you. Okay, I'm going to move us along a little bit. Obviously, sorry for that. If there are more questions, please chat them in. And so now I just wanted to take a little bit of time to go over the exercises that you all received. And so prior to the learning community, you all should have received an email or part of the invite with exercise 1, which was basically just doing a policy and practice scan of your organization, agency, program. And just to sort of get familiar, many of you may be already very familiar with what all your policies are. And so wanted just to take just a minute if anyone did want to share one or any issues or anything coming up with identifying a policy, we can certainly bring that up now. And then I will move into what the next exercise is going to be, which you all should have received yesterday. Was there anything that anyone had trouble understanding about what we were asking in the exercise? And many of you may have already done this previously.
This is Dr. Williams from Lafourche Parish.
Yes.
So I kind of pulled some different policies that we had. So again, our grant focuses on 1, 2, and a little bit 3. Because our facility is both a jail facility and a Department of Corrections DOC facility. And so when looking at our policies as it relates to mental illness and how to respond to crisis, we have something set in stone. Basically, we have guidelines for the patrol side of how to respond to a crisis call, how to guidelines in terms of working with somebody with a mental illness. However, we don't have anything solid in place for corrections. So basically, we're going by what the patrol people do. So that's something I think that we'll definitely take a further look at in terms of doing some sort of standard operating procedure specifically for the correctional facility. Because like I said, our CIT focuses on not only just the patrol officers, but also our correctional officers as well.
Okay, yeah, certainly, and I think this will be an opportunity to sort of get an idea of what that might be like in terms of revising policy that I think can sort of certainly carry over when you begin to look at the corrections side, corrections piece. So thank you. So I'm going to briefly just share the exercise with everybody. And so this is exercise 2. Is that showing up for people?
Mm-hmm.
Okay. Okay, so this is exercise 2. And so what we were looking to do is to have folks take the policy that they looked at and to then move into looking at the 6 principles of trauma-informed approach and how they can revise their policies to be more reflective with trauma-informed principles. And so what we were asking is, so for grant teams who have multiple agencies attending, we would be asking that you would each look at your own individual organization. So if you're a police department, looking at those policing policies and so forth. We're also looking to sort of recognizing that there are components and practices that are not changeable. I think we all need to understand as we move through policies, there are certainly going to be aspects that are there for a reason and cannot be changed. And so to that point, what we're looking for is how can we take a policy that exists now, pick it apart a little bit, see where we can sort of put in some trauma-informed language, and then have that move forward in terms of how it can impact practice. And so we do have some examples on here. So for example, under a mental health agency, I'm just going to read this is the example that we provide. So all participants accessing the behavioral health facility will do so through security, including metal detectors, and will remain in a single file line in a designated area until called by their assigned clinician. No participant should access the facility without a scheduled appointment. And so if that was your agency's policy, if you're a behavioral health agency, how could you take that and make it a little bit more trauma-informed, thinking of things like choice, collaboration, other things like safety. And so with that example, that's actually taken from an organization that I used to work for. And what they did in this facility, in this mental health facility, was they brought in a peer who staffed a resource desk. And so instead of people only being allowed there when they had an appointment, there was more of an open door to come by, talk with the peer, get some resources, maybe have a cup of coffee. And so it really did sort of change the environment a bit. And it didn't pose any other safety risks. All the officers it was a state building, so there were state police officers, so they still did what their procedures were. It was just a little bit more incorporating of the clients or the participants that you're working with. Since we are talking about law enforcement, so this policy I actually discussed with a retired police officer, and so when transporting a person in custody, they must be handcuffed for the officer's safety and be in a fastened seatbelt for their safety. And so what I learned both from talking with this retired officer and then actually a situation I saw in person last month was that the officers had some discretion when responding to a behavioral health call, that they had the option to not handcuff them if they felt that there was not a level of violence or other things that may require to put them in handcuffs. So again, looking at what can be changed, we know that there are certainly issues of safety with officers in the community, but this particular one, and the one I saw in person was actually in St. Petersburg, Florida, where the police responded to a woman that the convenience store owner had called, I believe, for possibly a trespassing. She wasn't causing a disturbance, and they did not put her in the police cruiser in handcuffs. They had her unhandcuffed. So to that point, I know we are short on time. So what we are looking to do is to take that policy you found and to revise it in this manner. And again, we will certainly be available in between sessions through email to answer any of your questions. So let me just get back to the presentation. So I'm going to just go in this format. And so for upcoming sessions, next session being on July 15th from 2 to 4, same time, Intercepts 2 through 3, Intercepts 4 through 5, our third session on August 19th, same time. And then for our fourth session, a follow-up session. And really the point of this session was to come back together as a group and just to hear some experiences about what it's like going back to your organizations and trying to implement a trauma-informed policy and practice. So that we're looking for possibly a phone call, a conference call or something like that. But we wanted to get that September 30th date out there from 1 to 2:30 for people to be able to check their calendars now. These slides will be made available to everyone, so you will certainly have all of the resources that we've presented here today. Here is all of our contact information. We are all also on the original invite, so our emails are there as well. And I do want to just say thank you to the whole group. I think this was an excellent start to the session, and certainly looking forward to the discussions continuing. You know, and I just to make this point before we do end, people have been asking about who they can have attend these learning communities. Our goal was to, even though if you were working in Intercept 0 or 1, but you saw other potential in the later Intercepts, we want you to attend. That's what this is about. So I will leave it on that, and thank you all for attending, and we will talk to you soon.
Thanks, everyone.
Thank you. Goodbye.